Hello, everybody. Welcome to this very nice ASST session entitled Mechanical Ventilation as an Art. So my name is Audrey de Jong. I'm the moderator, and I work in Montpellier, France, in the Department of Anesthesia and Intensive Care Unit of Professor Javert. And today I'm very pleased to be here because we have the honor to have two world-renowned speakers, Professor Davide CHIUMELLO and Professor Daniel Talmor, who will talk respectively about first mechanical power to stratify patients with ARDS, and then our non-intubated hypoxemic patients having acute respiratory distress syndrome. At the end of the two talks, you will be able to ask questions in the special eLives TV chat that you can see in your screen. So the questions are very welcome. Don't hesitate to ask questions, and we will answer to it with the two speakers at the end of this session. So we start now by our first speaker, Professor Davide CHIUMELLO. He's the head of ICU in ASST Santi, Paolo and Carlo, and is specialized in the treatment of serious disease of the respiratory system. He published a lot about it, and today he will talk about mechanical power to stratify patients with acute respiratory distress syndrome. Thank you very much, and thank you to Mindre for the support and to ASST to allow this session. Thank you, Professor CHIUMELLO.
Thank you, Audrey. I would like to thank the European Society of Intensive Care. So it is a great pleasure to be here. I have no conflict of interest regarding this presentation. So why it is important to evaluate the mechanical power? Here is a clear example what is the possible harm in a healthy lung. From left to the right, you can see a healthy lung ventilation with big tidal volume. So normal tidal volume, intermediate tidal volume, and big tidal volume. And you can see just after 20 minutes, so 20 minutes of mechanical ventilation with big tidal volume is able to injure in a gross amount the lung. And what is the possible effect, iatrogenic effect of mechanical ventilation in patients with ARDS? Here is a clear example. Whenever there is an increase in plateau pressure or in a driving pressure, is associated with a worse outcome. So starting from up to 20 centimeters of water of pressure, there is a significant increase in the outcome. And similarly, by increasing the driving pressure up to 15 centimeters of water, the outcome is significantly worse. But what are the forces implicated in developing ventilation and ventilator-induced lung injury? Pressure, esophageal pressure or pleural pressure, and the transpulmonary pressure. In the upper part of the figure is a condition in which at end inspiration, so without any flow, the transpulmonary pressure, which is developing to the lung, which is the difference between the higher pressure and the pleural pressure, because there is no flow and it is a spontaneous breathing, so higher pressure is 0, pleural pressure is, for example, -8, and the transpulmonary pressure is 80 centimeters of water. So by moving this patient in the operating room, so putting a ventilator and paralyze the patient, we can use a ventilator to inflate the respiratory system. And in this case, for example, we adjust the inspiratory pressure at 9 centimeters of water. The pleural pressure, in this case, is not negative, but is positive because there is mechanical ventilation, and the transpulmonary pressure is 8 centimeters of water. So this is an example in which it is possible to obtain the same transpiratory pressure, so the same pressure which distends the lung, which can injure the lung in two very different conditions of spontaneous breathing and paralyzed patient. What are the possible determinants of ventilation-induced lung injury? I summarize in this slide the possible factor, which is tidal volume, driving pressure, PEEP, respiratory rate, and what we have learned from several studies, which is one of the most important, that the ventilated patient with high tidal volume is able to increase the possible side effects. So study two group of patients, one group of patients ventilated with low tidal volume, so the very famous 6 ml per kilo against 12 ml per kilo. And here are our results. So by ventilator, the population with the same level of PEEP, but with two different tidal volumes, so two different inspiratory pressure and two different possible transpiratory pressure. As you can see, there is a huge difference in the outcome. But one of the problems is whenever we treat a patient with ARDS, the amount of the disease, so the amount of the baby lung, can be very different. So we have to not only setting the mechanical ventilation according to the size of the baby lung, but also looking at the driving pressure. So the driving pressure is the pressure which is necessary to inflate the respiratory system, and depends on the tidal volume, so the tidal volume that the physician adjusts to the patient, and the compliance of the respiratory system. So we can have the same driving pressure, for example, with a different tidal volume and with different compliance of the respiratory system. And why it is important to evaluate the driving pressure at the bedside? This was another famous study, retrospective study, in which it was clearly shown that by increasing the driving pressure up to 14-15 centimeter water was again associated to an increase in the mortality rate. So the protecting lung ventilation that we now use in a patient move from the use of very high tidal volume without PEEP or with a very low level of PEEP to a reduction of the tidal volume to avoid a lung overdistension, to decrease the transpiratory pressure, and to adjust PEEP to avoid the atelectic tremor, so the collapse at the end of each breath. But every time we increase the PEEP, we can affect the lung into different way. A positive way is to increase the amount of recruitment, and this can translate in a reduction of the atelectic trauma. But in the same time, every time we increase the PEEP, we increase the size of the baby lung, we increase the end expiratory lung volume. So we can, for example, by maintaining the same tidal volume, by increasing PEEP, increasing the possible effect of the volu trauma. High or low PEEP is still debatable. What we know and what we have learned come from this meta-analysis. It was revised, the randomized control study in which evaluate high and low level of PEEP. But in this meta-analysis, it was only look patient with ARDS, so the patient with the most severe form of respiratory disease. And as you can see, by applying high level of PEEP compared to low level of PEEP, again in patient with ARDS, high level of PEEP was associated with a significant reduction in the death of the patient and in significant reduction in the total use of the rescue therapies. Another point that often is missing of the physician is the respiratory rate. So the times in which the tidal volume is delivered to the patient. This was an experimental study in which, by maintaining the same inspiratory pressure, the author changed the frequency. So they changed the frequency from 20 to 35 breaths per minute. And the results are very clear. This was associated with a significant increase in the ventilation-induced lung injury, so in the amount of lung edema and the amount of perivascular hemorrhage. So how is possible to try to understand all these setting whenever we play? I would like to introduce the concept of the mechanical power and the concept of the pressure that is delivered in the patient. So the pressure which is spent on the patient is the pressure to generate a certain amount of the tidal volume, a certain amount of inspiratory flow, and a certain amount of PEEP. And this depends, the result of this pressure depends not only on the physician and only on the patient condition, elastance of the respiratory system, and the amount of the resistance of the patient. So the mechanical power tries to put all together this component, and this is a clear example how is generated and how is possible to compute the mechanical power. So this is the pressure and this is the volume. So the pressure, there are two components for the pressure. One component is the elastic component, is the pressure that is generated by maintaining the same level of PEEP. So at each breath, we have to overcome, so the pressure to overcome the elastic component of the respiratory system, so, and also the resistance component. And how is possible to evaluate at bedside the mechanical power? First, we have to understand if we have to ventilate the patient during volume control or pressure control, because it can be a short amount of difference, because in volume control, typically the inspiratory flow is quite constant. By on the contrary, with pressure control, the inspiratory flow is decelerated. And so this can affect mainly the respiratory component. So the calculation that we can apply to estimate the mechanical power during volume control ventilation is the respiratory rate, the tidal volume, the difference between the peak inspiratory pressure minus the plateau pressure and the PEEP. While during pressure control ventilation, there is also the respiratory rate, the tidal volume, the PEEP, and the pressure set on the mechanical ventilation. And here is a study in which we compare the two algebraic equations during volume control and pressure control, compare to the pressure volume curve, so the gold standard to evaluate the mechanical power. And this is the Brand-Altman, and this formula works quite well. Nowadays, it's possible to compute the mechanical power directly from a mechanical ventilator. This was another study in which we compare the mechanical power computed by the mechanical ventilator and by the algebraic formula. And it was found a good correlation between the two with a low amount of error between the two measurements. But what are the available data on the possible effect of mechanical power to promote the ventilator-induced lung injury? This was an experimental study in which a group of healthy animals underwent a different amount of the mechanical power. And as you can see, higher is the mechanical power, higher is the worst effect in the lung edema. So the increase the lung weight evaluated CT scan. And this can also be associated to a decreasing of oxygenation. So high is the mechanical power, high is the lung edema, and worse is the oxygenation, and then can also translate in the impairment of the mechanical characteristic of the lung, a significant increase in the lung elastance. But how can affect the tidal volume, the driving pressure, respiratory rate, and PEEP on the mechanical power? Here is the percentage change of each of these components, and as you can see, whenever we change the tidal volume, contrary to change of PEEP for the same percentage of, for example, decrease or increase, the mechanical power is very different effect. So the tidal volume significantly more affect the change in the mechanical power compare the change of PEEP or respiratory rate. And what are the evidence of the mechanical power as a heterogenic of possible ventilator-induced lung injury? This was a retrospective study in which were analyzed more than 2,000 patients, and in this study, the mechanical power was evaluated at admission, and higher is the mechanical power, higher was the mortality, intensive care, and also 30-day mortality rate. And it seems, we don't have too many data regarding the mechanical power and the association of the mortality, but from this study, it seems that the mechanical power higher than 16, 17 joules per minute was associated to increasing in mortality rate. This was a study that we performed in a group of ARDS patients, and we evaluate not only the mechanical power, but we adjusted the mechanical power according to the size of the baby lung, so and to the characteristic of the lung. And as you can see, seems that the correct mechanical power, so according to the size of the baby lung, according to the compliance of the respiratory system, was associated to the outcome. So how we can conclude? The mechanical power seems to put all together the component that can induce and can modulate the ventilator-induced lung injury. And the effect, the change of each component can significantly affect the mechanical power. At the present, we don't have too many data regarding the possible limit of the mechanical power. There is just one study in which the mechanical power higher than 67 joules per minute can be associated to a worse outcome. And another important point that we have to have more data is which is the size of the baby lung. So because in my opinion, it is important not only the amount of the mechanical power, but how the mechanical power is transmitted to the lung. Thank you very much.
Thank you very much, Professor CHIUMELLO, for this very nice talk about how to stratify the risk of ARDS with mechanical power. And I think the audience has a lot of questions that, again, they can ask through the chat on eLive's TV chat. And then we will answer to it. We will try to answer at least at the end of the session in the last 15 minutes. Now I have the great honor to introduce Professor Daniel Talmor. Professor Daniel Talmor is the chair of the Department of Anesthesia, Critical Care and Pain Medicine at Beth Israel Diaconess Medical Center, and is professor of anesthesia at Harvard Medical School. Dr. Talmor's research interests are centered on the early identification in treatment of critically ill patients, with a particular focus on the optimal delivery of mechanical ventilation, which is perfect for the topic of today, are non-intubated hypoxemic patients having acute respiratory distress syndrome. Thank you very much, Professor Carlo.
Thank you. Thank you very much, Audrey, and thank you to ESICM and to Mindray for inviting me for this talk. So I received actually, I think, a pretty difficult topic here, which is more of a philosophical topic than a data topic, and that is, do non-intubated hypoxemic patients actually have ARDS? And these are my disclosures. So if we go back 55 years to the first report of ARDS in the Lancet, we will remember that we've been arguing over the definition of ARDS for those entire 55 years. And definitions come and definitions go. Our most recent ones are these, the Berlin criteria, and that takes 4 parameters: the timing of the disease, the chest imaging, the origin of the pulmonary edema, and the degree of the oxygen deficit. But if you really look into these parameters for the definition of ARDS, you'll see that they're not very different from the definition of acute hypoxic respiratory failure. So both are acute diseases, and it's in the name. Both are non-cardiac events, so they are primarily respiratory events. Both involve significant hypoxemia. Really, the only change in definition is that acute hypoxic respiratory failure doesn't necessarily have to have a bilateral opacities on the chest X-ray. So if they're essentially the same, except for the chest X-ray, does the chest X-ray mean anything? And, you know, we're very familiar from various reports of the classic typical chest X-ray, and subsequently we learned what the classic typical CT looked like in ARDS. But we've known for years that physicians aren't very good at interpreting chest X-rays. And there's a wide variation in how clinicians look at the same chest X-rays, and many people will call bilateral infiltrates, others will call unilateral infiltrates, and others will say that's a normal chest X-ray. So it's very difficult to add the interpretation of a chest X-ray to our definition of ARDS. And what about the outcomes? So are outcomes influenced by the chest X-ray? And this very interesting paper from the European Respiratory Journal a couple of years ago demonstrated that actually the outcomes are similar in unilateral and bilateral disease. So it really doesn't matter if you have bilateral infiltrants on your chest X-ray, you will have the same outcome of disease. So the chest X-ray criteria, which really differentiates ARDS from acute hypoxic respiratory failure, doesn't seem to be that important. Now, hidden in the definition of ARDS there is the fact that the oxygen deficit has to be on PEEP. And this paper from Caironi showed that actually lower levels of PEEP are more predictive of lung recruitability and subsequent mortality. So does high levels of PEEP influence the oxygen criteria? No. And in fact, a lower level of PEEP, the lowest, a PEEP of 5, may be more appropriate. And that's very relevant to the question at hand, because when we ask if non-intubated patients can have ARDS, we have to ask, is the assessment of oxygenation in the non-intubated patient valid? And here we see that lower levels of PEEP, which are easily delivered by non-invasive ventilation and perhaps by high-flow nasal cannula, are an appropriate level of PEEP to assess the oxygen deficit. So literature supporting the fact that you can have ARDS and actually meet the definition of ARDS while you're not intubated. And finally, what is ARDS anyway? So this is a really interesting paper from 10 years ago where Arnaud Thiel took patients who had died with a clinical diagnosis of ARDS and checked what their actual pathological diagnosis was. So he divided these into patients with mild, moderate, and severe ARDS. And he found that actually, particularly for mild ARDS, most patients who died with the clinical diagnosis of ARDS didn't have the pathological hallmark of ARDS, which is diffuse alveolar damage. In fact, what we call clinical ARDS may be many, many different things, from actually pretty intact lungs, pneumonia, or the classical diffuse alveolar damage. And we know that. We know that the pathology of ARDS, or the syndromes which make up the syndrome of ARDS, there's many of them, right? There are pancreatitis, hypersensitivity, PCP, mycoplasma, severe sepsis. All of these can be patients with ARDS. And the picture's gotten even more complicated recently. So this is our new friend, COVID-19, showing that the pathology of COVID-19 can include diffuse alveolar damage, although it can also include lungs that look pretty normal. So, and during COVID-19, we spent a lot of time arguing whether COVID-19 was actually acute respiratory distress syndrome. Did it meet the definition? Should it be treated as the same as we would treat a patient with ARDS? Very smart and influential members of the critical care community argued that it's a new disease. Others argued that it's very similar to what we've classically called ARDS. In the end, the severity of hypoxemia is most closely associated with mortality, and that's irrelevant to the diagnosis of ARDS. So this is data from the Lung Safe trial showing the probability of hospital survival by the degree of hypoxemia. Mild ARDS, mild hypoxemia, better survival; severe hypoxemia, worse survival. So to sum up, does it matter if we put diagnosis of ARDS on a patient? I would say that probably the term ARDS has lost any relevance now. What we're dealing with is acute hypoxic respiratory failure. We can treat acute hypoxic respiratory failure by intubating the patient, or we can treat it by non-invasive methods. So is the question important? Yes, it is. And if we have unintubated patients with ARDS / really should say acute hypoxic respiratory failure, is it wise to leave them unintubated, or are they at risk of exacerbating their lung injury by spontaneous ventilation while their lungs are sick? And in other words, does patient self-induced lung injury exist? And really, I'm going to pivot the rest of the talk from the question of do non-intubated patients have ARDS to what do we actually do about it? And I think that's the more important question, because the presence or absence of an endotracheal tube doesn't really change your condition. It's does that presence or absence of an endotracheal tube make a difference to your outcome? So to talk about patient self-induced lung injury, we have to go back to our basic pulmonary mechanics. And I'm going to remind everyone that the pressure that we're actually interested in a patient who's ventilated is not the airway pressure, it's the transpulmonary pressure. And the transpulmonary pressure is the airway pressure minus the pleural pressure. So it's the airway pressure minus the pressure which is expended in pushing out the chest wall. And on the left side, you can see a mechanically ventilated paralyzed patient. They're attached to a ventilator, and the ventilator is delivering 20 centimeters of water pressure. Now, the chest wall in that patient is pushing down on the lung and has to be pushed out with the ventilator, with the ventilation. So if we apply the pressures to that algorithm above, we have 20 centimeters of water pushing out a chest wall, which weighs, let's say, 5 centimeters. So 20 minus 5 is 15 centimeters of water, and that's the transpulmonary pressure. That's the pressure being applied to the lung. Now let's take a second patient, okay, the patient on the right. That patient is spontaneously breathing room air. So there's no positive pressure in the lung, but the chest wall is actively expanding, causing negative pressure in the thorax. So the transpulmonary pressure is now 0 airway pressure minus a negative 5 centimeters of water of pressure in the thorax. So negative is positive, and the transpulmonary pressure is 5 centimeters of water. Now, everything else being equal, lower transpulmonary pressure, less lung injury. Now, what happens when that patient who's spontaneously breathing gets non-invasive ventilation? So now we've taken the spontaneously breathing patient and we've applied non-invasive ventilation or high flow nasal cannula or some form of positive pressure. So now the airway pressure is positive, okay? It's, let's say, 10 centimeters of water. No one really knows what the airway pressure is with high flow nasal cannula, but it's probably positive. We definitely know that non-invasive ventilation applies positive airway pressure. So we have an airway pressure of 10 centimeters of water. It is being applied during spontaneous ventilation. So that 10 centimeters of water, we then take away negative 5 centimeters. The transpulmonary pressure is 15 centimeters, the same as under mechanical ventilation. Okay, so the lung stress in a spontaneously breathing patient during non-invasive ventilation can be equal to the lung stress in a patient who's mechanically ventilated. And that's important to remember because while it may seem less invasive, we may be applying the same stress to the lung as we are when the patient is ventilated. And I'll show you what that stress can look like. This is actually a ventilated patient. We have tracings of their airway pressure, their flow, their esophageal pressure, and their transpulmonary pressure and volume. So we're going to concentrate on this breath here. And you can see that we've delivered a mechanical breath, but right away, the patient has taken a spontaneous breath as well. That's that negative deflection in the esophageal pressure. So those breaths now stack, okay, because there's a spontaneous breath on top of the ventilator breath. That will lead to an increased tidal volume, which is the strain on the lung, and an increased transpulmonary pressure, which is the stress on the lung. So this is how it looks in a ventilated patient. How might it look in a patient undergoing non-invasive ventilation? So here's a patient on helmet ventilation, and I took this from a review in Minerva by Greco. You can see the second line is the airway pressure, and this patient is getting a pressure support of 10. The next line is the esophageal pressure deflections with the patient's spontaneous breathing, okay? And below that is the calculated transpulmonary pressure. So this patient who is breathing deeply, spontaneously, is actually generating very high transpulmonary pressures on helmet ventilation. This may be as bad as or worse than actual mechanical ventilation. So while we think that non-invasive ventilation may be more gentle on the patient, that's not true in every case. And it really may depend on the patient's respiratory efforts. And these are esophageal pressure tracings in 6 patients on non-invasive ventilation. And you can see very different respiratory patterns in these patients, depending on the severity of their illness, the severity of their air hunger, the severity of their, or their level of sedation and how that may affect their spontaneous breathing. Up here on top, this patient has esophageal pressure swings of 20 centimeters of water. That's going to cause huge transpulmonary pressures. Down here, this patient is much calmer. the swings are only 7 centimeters of water. So in patients who are really breathing hard, the differences in transpulmonary pressure, which remember is the stress on the lung, may be huge. And we may want to rethink which patients we put on non-invasive ventilation. There's actually more evidence that patients who are spontaneously breathing may be at more risk for focal lung injury. So in the normal lung, there's a continuous fluid-like behavior of the pleural space. The lung expands uniformly across the pleural space. That's not necessarily true in the injured lung. So this is data from Yoshida and Brochard, Kavanaugh, demonstrating that in injured lungs, the negative swing in pleural pressure may not be uniformly transmitted and may actually affect the posterior dependent lung areas more. So these patients who are breathing spontaneously and making huge efforts, not only are they generating huge stress, they may actually be focally injuring the posterior portion of the lung. And that's because the pattern of distribution of a spontaneous breath is different from that of a mechanical breath. And you can see this here on EIT. Here, the spontaneous breath is more posteriorly distributed than a mechanical breath, which is more in the mid-lung area. And looking at strain mapping in the spontaneously breathing patient, we can see increased strain in those posterior areas because of the different distribution of the air during the spontaneous breath. So to sum up, spontaneous breathing may increase the strain on the lung. That lung may be particularly increased in the posterior portions of the lung, putting them at higher risk for lung injury. Now, spontaneous ventilation may help us. This is data from Ewan Gallagher's group in Toronto, showing that spontaneously ventilated patients actually preserve their diaphragmatic function compared to patients who are not breathing spontaneously. So the evidence isn't all against spontaneous ventilation. It's against spontaneous ventilation in the sickest patients, those who are breathing hard and generating huge lung stress. And that was demonstrated pathologically, again, by Takeshi Yoshida in this very good paper, where he showed that mild injury with spontaneous breathing actually preserves the lung architecture, while severe injury with spontaneous breathing makes the lung architecture worse, injures the lung, and may lead to further hypoxic respiratory failure. So we've learned that stress may be increased in patients who are breathing spontaneously. There is a good physiologic rationale why that may injure the posterior portions of the lung. And it's worse in patients who are severely injured, who are also going to be the most dyspneic. You get a vicious cycle of injury. So this is taken from a review by Laurent Brochard. You have the initial lung injury, the capillary leak, the lung edema, the impaired gas exchange. That increases respiratory drive, which further worsens the patient self-induced lung injury. And that's where we have to be careful. At what point do we break this vicious cycle and say, we are going to ventilate the patient, let the patient rest, and hopefully prevent this patient's self-induced lung injury? Now, this is, there are studies out there. This is the Floralie study from France, which showed the feasibility of using non-invasive ventilation in patients with essentially ARDS. Okay, they randomized to non-invasive ventilation, standard oxygen, high-flow nasal cannula, and they showed that high-flow nasal cannula in particular was associated with less intubation and better mortality in the ICU. Unfortunately, they didn't tell us what happened to the same patients who weren't in the trial. So we can't really compare this to ventilated patients. But it is feasible in the right patient not to intubate a patient with hypoxic respiratory failure and leave them on non-invasive ventilation. Does that succeed? So we have data from the LungSafe trial. If you recall, the LungSafe trial was a global study of patients with a diagnosis of ARDS. And some of those patients, about 15% of the patients in the study, weren't intubated on day 1 and day 2. What they found was that 30% of patients who were not intubated failed and had to be intubated. Another 20% actually had limitation of care, which means they weren't going to be intubated no matter what. So all in all, the failure rate was at least 30% and may have been closer to 50% if you take into account the patients with limitation of care. So if you are going to use non-invasive ventilation and leave patients with ARDS not ventilated, you have to be prepared that some of those patients will fail and you have to have a backup plan. Which patients were not ventilated? So we see here patients who received invasive mechanical ventilation. These are paired matched patients. We see the patients with non-invasive ventilation. And there were differences in their parameters, okay? So the minute ventilation was much higher in the patients under non-invasive ventilation. Their tidal volume was significantly higher. And I think most importantly, their respiratory rate was significantly higher. So we just learned from Davide that respiratory rate, tidal volume, and minute volume all will increase the mechanical power applied to the lung. So while we think these patients are getting a less invasive form of support, maybe it's not less invasive. Maybe we're actually worsening the lung injury with an increased application of mechanical power to the lung. Now, I'm not going to argue that, maybe it's better to leave certain patients unintubated, but I'm just saying that we have to be thoughtful about how we do that. And this is the outcome from that study of patients on non-invasive ventilation. And you can see for the less sick patients, okay, it looks like the non-invasive ventilation was less good. Those patients did better when they were invasively mechanically ventilated. The same was true for the sicker patients, the P/F less than 150, but there it didn't quite reach statistical value. So all things being equal, think very carefully before you leave a patient unventilated. And of course, this question really became crucial during COVID-19. And, we as intensivists really swung back and forth between early intubation and then, which I think most of us followed in the first wave in March of 2020, to then overcorrecting and saying, well, we intubated too early. Perhaps we were too scared of patient self-induced lung injury. And we went back to long trials of high flow nasal cannula. And then saw that that didn't necessarily work, maybe swang back to early intubation. This is data from the REVA network of COVID ICU investigators. They took 4,700 patients admitted to the ICUs across 3 countries, so very large trial, and were able to analyze about 4,200 of those patients. About a third received non-invasive ventilation of some type, either oxygen or high flow nasal cannula or non-invasive ventilation or a combination of all those. And they found that actually the oxygenation failure rate was pretty high, about 50% across the board. And 90-day mortality was actually also high, particularly in the non-invasive ventilation group. So the COVID REVA group demonstrated that leaving patients on non-invasive ventilation may have actually injured some of those patients. And the question then is, at what point do we transition patients who we've given a trial of non-invasive ventilation to actual mechanical ventilation? So there's been previous work on this. This is the HACOR, I don't actually know how you pronounce it, HACOR score to identify non-invasive ventilation failure. It's based on the heart rate, pH, Glasgow Coma score, oxygenation, and respiratory rate. It works quite well. But what did we do during COVID? So this is data. It was published in a not great journal, but it showed early recognition of non-invasive failure in COVID patients, and it showed that patients in whom we didn't recognize this failure early, they had an increased mortality, and this was in relatively not sick patients, SOFA score less than 9. This paper out of Japan showed that patients who were not intubated early, and there the definition of being intubated early was an O2 requirement of 6 liters. So patients who didn't receive early intubation had an increased in-hospital mortality, 28% versus 16%. They spent more time on the ventilator, and in the end, they required more ECMO. So I don't have a good answer to tell you exactly when to intubate the patient on non-invasive ventilation. What I do hope is that after this talk, you're going to remember that non-invasive ventilation is not necessarily less harmful ventilation, that we need to be looking carefully at the patient. We need to remember that ARDS is really an amorphous entity. It's hypoxic respiratory failure, that patients who aren't intubated can have ARDS. The real question is, do we use this insight to change care? The real issue is, do those patients have a risk of patient self-induced lung injury? And I hope you'll understand that that is true, that they are at risk for that. Time-limited, non-invasive / high-flow nasal cannula / whatever you use, helmets, whatever, may be appropriate. But if it's not working, and I would generally say if it's not working after 24 hours and we're seeing a patient continuing to struggle, I would strongly consider intubating the patient and allowing the patient's lungs to rest. So thank you very much, and I'll be very happy to answer questions.
Thank you a lot, Professor Talmor, for this very impressive talk. I think we learned a lot. And we have many questions in the eLife's TV chat. And the first question is for Professor CHIUMELLO, and is about the components of mechanical power. Some people are astonished that PEEP is incorporated into the equation because for them, PEEP can't be harmful. So does it mean that PEEP can be harmful in patients with ARDS? And are severe and mild ARDS the same? And a similar question about why incorporating resistance into mechanical power, as resistance is more related to airway than lungs.
Okay. Thank you very much. So the role of PEEP in a computation of the mechanical power is a big dilemma. In my opinion, I like to have in the computation of the mechanical power the PEEP, because it's the pressure necessary to distend in a static fashion the respiratory system. So it's a pressure that is generated by the ventilator, and up of this pressure is applied the tidal volume. And every time we increase the PEEP, so we have to use higher pressure to maintain more inflate the lung. And PEEP can be harmful because every time we increase PEEP, for example, the price that we have to pay not only to the pressure inside the respiratory system by the mechanical ventilation is the hemodynamics, because when we moving from spontaneous breathing to control mechanical ventilation, we can have a reduction in venous return. There is hypotension, so we have to give fluids, inotropes. So this is the physiology, and we have to pay a lot of attention. Regarding the role of the resistant, it's true that the component is spent to move the air into the endotracheal tube. But there are some very recent data that also the resistance of the airway can be affected by the shape of the flow and the amount, the peak inspiratory flow. So this is another point that there are not many data, but I know there are several studies going on this topic.
Okay, thank you very much. We had another question about mechanical power. And one other question is, does the patient have to be completely passive, mechanically paralyzed to calculate mechanical power?
Not completely paralyzed. The patient does not have an inspiratory effort. So if the patient has a very high level of sedation and there is no inspiratory effort, you can compute the mechanical power.
Okay. Thank you. We have other question about it, but first we will ask other question to Professor Talmor as the time is running. And the first question is, do you think that diffuse alveolar damage, DAD, should be the equivalent to the definition of acute respiratory distress syndrome?
So good question. It's I will be honest, I would retire the term acute respiratory distress syndrome. I think given that it really has so many different possible etiologies, it's not that useful. And as I tried to point out, it's really no different from acute hypoxic respiratory failure. And we treat syndromes that are very different the same way. And we had this argument in COVID, does low tidal volume ventilation and PEEP, are they appropriate in COVID patients? And I think most people landed on the answer yes. So I would instead of using the term ARDS, and we can't really diagnose diffuse alveolar damage when the patient's alive anyway. I would, instead of using ARDS, try to be more specific. This is acute hypoxic respiratory failure. I think there's a lot of interesting data being accumulated by Carolyn Calfee and her group on hyperinflammatory and hypoinflammatory acute respiratory failure that I would like to see us move beyond using that term ARDS. The term, the label of ARDS is useful in clinical trials for saying this is a clinical trial of ARDS. It's not useful at the bedside.
Okay, thank you. And another question is about the limit of transpulmonary pressure. Do you think that the limit of transpulmonary pressure is the same in intubated and non-intubated patients?
So there's not good data on what the safe limits of transpulmonary pressure are in either intubated or non-intubated patients. A patient at taking a large breath, a spontaneously breathing patient can get up to a transpulmonary pressure of 20 centimeters of water simply through expansion of their chest during a deep breath. That's probably not safe. If you did it, 25 times a minute for hours and days, you would probably injure yourself, but there's no data to support that. What we do know from our EpiVent trials is that the transpulmonary pressure at end inspiration the higher, the worse the patients did. Now, that may be because those patients were just sicker, but high transpulmonary pressure at end inspiration seems to be associated with worse outcome. So I think they're equivalent. I can't prove it, but I do know that higher is worse. So we need to try to limit the transpulmonary pressure, whether the patient is breathing spontaneously or mechanically ventilated.
Okay, thank you again. We have a lot of questions about how to move from non-invasive ventilation to invasive mechanical ventilation, how to choose the moment. Are there any criteria? Is mechanical power useful? ROX index, what about the ROX index to predict it and maybe to choose to move? The audience is very interested by this topic on how to choose finally. I think it's a very difficult question.
It's a very difficult question, and I would say that this is a purely clinical question. You need to be looking at your patient every day and seeing, assessing not only their labs and how their gas exchange is going, but how that patient looks. Are they struggling? Are they breathing deeply? Are they very tachypnic? I think mechanical power is an extremely useful concept. You can argue about which formula to use, but really at the base of it, mechanical power adds respiratory rate to the calculation of the airway pressures and the tidal volume. So that is useful, and I think very important, particularly in spontaneously ventilating patients. I will say anecdotally, in our experience here, when we left COVID patients on non-invasive ventilation for 4, 5, 6 days, or we had patients that we received from outside hospitals who'd been on high flow nasal cannula for 2 weeks. When those patients got intubated, their mortality rate was awful because they had developed severe what seemed like pulmonary fibrosis from long-term non-invasive ventilation, and they essentially all died, and it took a long time. So what would I do at the bedside? I would look at the patient every day. I would say if the patient is not getting better after 48 hours trial of non-invasive ventilation, I would probably intubate the patient. But that's just my personal practice.
Thank you for this very clear message. Maybe Professor CHIUMELLO, you want to talk about it, or there are also other questions about mechanical power and the association with mortality. Overall, all questions ask the question of the chicken and the egg. Is a good setting of mechanical power associated with reduce of mortality, or is just mechanical power a marker of the severity of the disease? Again, a difficult question.
Difficult question. What is possible is the physician can modulate the mechanical power by adjusting the norm of the ventilator and, for example, change the compliance of the respiratory system, the resistance. So the mechanical power is a useful indicator to understand what is going on that patient, and how by changing the tidal volume, respiratory rate, and PEEP can affect the mechanical power. Because sometimes we think only about, okay, we have to reduce the tidal volume because we have to reduce the transpulmonary pressure. But in the same time, if we do the tidal volume and we increase the respiratory rate, maybe the mechanical power can be the same or higher. So this is the utility of the mechanical power at bedside. You understand what is going on. Regarding the level of the mechanical power associated to the possible increase, we don't have enough data. But what we know, high is the mechanical power, high is the mortality rate, and high is the mechanical power, high is the hemodynamic impairment. So the price that we have to pay by giving fluid, by giving inotropes, the possible kidney injury.
Okay, thank you very much. And we had a lot of questions, but the time is running and it's time to conclude. So thank again for the audience for attending and for all the questions, very interesting that were raised. Thanks a lot to the two speakers with very, very interesting talk. And thanks again to the ESIGM organization, especially Elise and Anna. And of course, thanks for Mindray for their support in organizing this event. So I hope you enjoyed, and thank you again to Professor CHIUMELLO and Professor Talmo.
And let me thank you, Audrey. Thank you very much for being
Thank you very
gracious.
much. It was a great pleasure. Bye, Daniel. Bye, Audrey.
Bye.
Bye-bye.
Bye-bye, everyone.